NCDs. But before we get into the panel discussion, I'd like to call out one of our sponsors, Vitality Health International, Ms. Emma Knox, who is the Chief Executive Officer. So she will come in for a short presentation and then we'll jump right into our panel discussion. So you're welcome, Ms. Emma. Good afternoon. It's such a pleasure to be here and have the opportunity to talk to you about the important topic of men's health in Africa, and particularly about NCDs. My name is Emma Knox. I'm the CEO of Vitality Health International. For those of you who don't know, Vitality Health International is part of the Discovery Group. Discovery is a South African company and has been expanding globally. It's now present in 40 countries worldwide with about 30 million lives cover. And at the beginning of this year, we launched to the rest of Africa. We're now live in Kenya, Nigeria, Zambia, the DRC, and just last week went live in Mozambique. And today I've got the opportunity to spend just a brief 10 minutes with you to talk about some of the highlights around men's health in Africa, around why it requires a different focus, and the importance of screening and wellness, particularly in health prevention, the role of technology, and the focus on wellness, equality, and value. Before we go into the role of men and health, I wanted just to pause and talk about the broader context in Africa and the challenges of healthcare access. We know that in Africa, there is extreme burden of disease with non-communicable and communicable disease. There's a limited number of doctors per individual, and there's low private healthcare insurance penetration. And these together create a real challenge for access. And at Vitality Health International, we believe there's a strong role for the private sector to do more, to provide more access to wellness, screening, and prevention, and remove some of the burden for the broader system and then benefit the society as a whole. When we talk about men's health, the first question is really, why men's health? Why is this important? And we've talked quite a lot about that this morning, so I'll just touch on a few key elements. Firstly, men in the room, that you are more likely to engage in risky behaviors. We know that men, according to the World Bank, are much more likely to smoke than women, 5 times more likely to smoke. In sub-Saharan Africa, we know that 18% approximately of men smoke, whereas less than 3% of women. But this is not unique to smoking. It also happens with alcohol abuse, with poor diet. And so we see that there is an increase in the risk factors linked to hypertension and diabetes, which lead to men having a higher incidence in these areas. And then the additional burden is not only is the incidence higher, but when men present later. This has been talked about this morning. Men wait till they are really sick before they go to the doctor. And this means that the intervention is often much more severe, it takes you to secondary care, and the outcomes are much worse. So it's this double burden of the increase in risk factors, the higher incidence, and the late presentation, which creates the increased burden for men and the need to intervene differently. In resource-constrained regions, it is even more important to have prevention and screening. When there are limited numbers of doctors, limited access to healthcare, long distances between people and secondary care facilities, the importance of screening is extremely important. You can see the pink line here, which is rising sharply. And that shows the increase in non-communicable diseases over time. This is already a significant burden in the African region. It's only going to increase more over time. One positive thing about NCDs is that we know that if you intervene early, you can have very significant impacts at low cost at primary care centres. If you're able to catch someone when they're pre-diabetic rather than diabetic, if you can catch high blood pressure rather than someone have a heart attack, the outcomes are significantly better. Sorry, can you go back a slide? Thank you. When we talk about early screening and prevention, we know that catching it early is important. And on the chart behind me, you can see an example in terms of oncology. We know if you catch cancer at stage 1 or 2, your outcomes are extremely better, extremely much more beneficial to you than if you catch it at stage 3 or 4.
But this is not unique to oncology. It's the same for diabetes. It's the same for heart disease. If we can catch something earlier, we can do much more cheaply, and much more at a point of care that's close to you. And this is really the central premise around making sure that through Vitality Health International, we offer a lot more screening and wellness at the beginning. So offering support for you when you are well, not just when you are sick. So what can we do to help men interact with healthcare professionals more, to present earlier? And I think there's a strong role for here in technology. We know that often people have busy days. It takes time out your day to go and see a doctor, but also it's embarrassing. And it might be socially unacceptable to be waiting in a clinic all day, be seen at that clinic. And therefore, the opportunity to have technology to take some of that burden away is a really important opportunity, I think, in the Africa region. Through apps and telemedicine, men and women are able to more easily interact with doctors, gain prescriptions, gain blood tests at their point of care. And this again can mean that care happens earlier and screening happens earlier. African population is young. We know that 3/4 of the African population are under 35. And this group are tech savvy, and they're keen for looking for digital solutions to not only track, but improve their health. So for Vitality Health International, what we've looked at as a private healthcare insurer are some of the challenges that I've mentioned around access to healthcare, some of the themes I've mentioned around the importance of screening, but also the growing middle class being increasingly digitally savvy. And we've designed a product specifically for the African market. It's not the same as the product in South Africa. It's not the same as the product in the UK. It's designed specifically for Kenya, specifically for Nigeria. And with those products, we offer care either within your country. So if you're based in Kenya, you can choose an option that covers you just in Kenya. You can have an option that covers you Africa roaming and including India, or you can have a truly worldwide product which covers you globally, just excluding the US. And the important differentiator for us here is that we have our Vitality Behavioral Program embedded with all of these plans. So if you are insured by Vitality Health International, at the beginning of that insurance, we do a comprehensive screening. We come to your place of work, we do the screening from BMI to blood glucose, blood pressure, so that we're picking up risk factors early. We then work with you that you have individual goals, personalized goals every single week on what is your next best action. That next best action might be screening. It might be going for a mammogram, might be going for a prostate check. It might be going for a 10,000 step walk. It might be focusing on your mental health, getting more sleep, doing meditation. We have different goals depending on you as an individual. Next slide, please. And if you achieve those goals, you get rewarded. And we all know that health is important. We know it improves your longevity, but actually being reminded of that every single week and being incentivized to do that every single week makes a significant difference. So we incentivize you, we set you your goal. If you achieve that, we reward you. So here we can reward you with a Vodacom or Safaricom voucher, with an Uber Eats voucher, with Jamia, or if you choose, you can donate that reward to UNICEF. And by incentivizing people, we know regardless of the condition, we are able to increase the amount of screening that's done. And this is really important to improve health outcomes. And with our data we've collected over the last 20, 30 years, over this 30 million patient cohort, we can see a really strong linear relationship between engagement and outcomes. You've got employers here as well as employees. And as you are more engaged, you can see your loss ratio, the amount that you claim, decreases significantly. This is important to the employee. It means you're going to the doctor less, you're healthier, you're more well. It's important to the employer because it means you're likely to be more productive, you're having less sick days, less days off work, and you are collectively offering more to society. My final slide before we move into the panel session. I've talked about the importance of physical activity and wellness. I think one of the things that's most interesting is it's not that you have to do a huge amount to make a major impact. So if you just exercise 1 day a week, we have seen a 35% reduction in mortality. That's just exercising 1 day a week. So if you're thinking of going to the gym this week or going for a run, it's probably a good idea. And we talked in the morning in the opening plenary session about life expectancy. If we look in South Africa, where we've got a lot of data with Discovery, we know that life expectancy there on average is 64 years. If you have private health insurance, it increases to 67 years. If you're engaged on our Vitality program, just engaged, it goes up to 83 years. That's saying that if you are doing basic screenings, some basic health activities and eating healthily, you can change your life expectancy considerably. And if you are one of our gold or diamond members, which means you are fully engaged, you're exercising regularly, you've done all of your appropriate screenings, that life expectancy can shift to 89, which, as you can see, is even better than places like Japan, where we know that life expectancy is very high. I'm going to stop there, and we're going to go into the panel session now, where we're going to talk about some of these elements in a lot more detail. Thank you.
Thank you so much, Emma, for setting the stage pretty much for the next session this afternoon. I'd like to take this opportunity to invite the moderators, the moderator and the panelist for this plenary session, which is titled Reducing the Burden for NCDs for Men in Africa. So I will invite the moderator and the panelists, and as they come up, I would like to invite I'd like to introduce the moderator for our session, who's going to be Dr. Shisanya Kizito Asava, who's a surgeon and a senior lecturer at Kenyatta University. Karibu sana, Daktari. I'll also invite Emma Knox once again. Thank you for that insightful presentation. Emma Knox, again, is the CEO of Vitality Health International. So please kindly set yourselves on stage. Next, I will invite Miss Nelly Ale, who's the head of health ecosystems at MasterCard Foundation. And last and definitely not least, I will introduce Dr. Vincent Hongo, who's the Chief Executive Officer of Chiromo Hospital Group. I invite you to take your seats and to listen as we find ways and solutions and strategies to curb the rising trend of mental and non-communicable diseases for men in Africa. Karibu sana, Daktari, and all the panelists. Okay.
Yeah, good afternoon, everyone, and thank you for joining this session. I will have the privilege to lead the panel in terms of responses. At the onset, if you pick an issue you'd like us to address, kindly note it down and make it find its way to her so that we are able to capture it in this session if it's really necessary. To make it also interactive, I'll be glad to have 1 or 2 comments from the audience. We will have a fraction of this session, a quarter of it that we will bring to the audience to participate. I've had introductions already. We have some of that in the bio in the booklet. But I know I would like us to know a bit more from them. So I would like them to spend half a minute to tell us more about them, other than what we have had from their names. So we'll begin on my left. Today we're discussing men. So men first.
Good afternoon, everyone. It's a pleasure to sit here with my teacher, Dr. Kizito, and my colleagues, panelists. Thank you. Thank you for the invite, all protocol observed. I'm also happy to sit in the presence of the First Lady of Kisumu County, my mom, where I come from, my villager. Thank you. I'm Dr. Vincent Hongo, the CEO of Chiromo Hospital Group. It is a level 5 specialized mental health psychiatric facility, a first of its kind in sub-Saharan Africa. Thank you.
Thank you very much. I think I'll go to my far right to have her tell us a little about herself, Emma.
Thank you. I think I stole the beginning and gave a very long introduction to myself, but if anyone missed that, my name's Emma Knox. I'm the CEO of Vitality Health International, which is a private health insurer focused on prevention, wellness, and promoting support for you when you're well, not just when you're sick.
Thank you. And lastly, we'll have Nelly. This is just for us to at least get to know who are these people speaking to us. Please go ahead.
All right. Good afternoon, everyone. My name is Nelly Ale from the MasterCard Foundation. I head our health ecosystem portfolio, and our focus is on digital health, health financing, and also private sector engagement. And NCD is really my heartbeat, and so I'm excited to be here. Thank you.
So thank you. So I was tasked to ask a few questions, and I hope you will do justice to it. So describe what are the hindrances, what are the challenges, what are the issues that, with regard to awareness to NCDs, that men relate to or refuse to relate to, and as a personal touch would be very good, so that these people can identify with it as well.
Thank you, my teacher. You know, he's asking me as a man not as a student in cutting through abdomen, but it's very important that we've had this better. Thank you. A lot has been said this morning. A lot has been said before this morning in matters health amongst men. We are very happy and very proud of this institution that is now focusing on men's health. As a man, I would tell you that we are viewed differently by women and men. We've gone through it, and we know very well that the way the society has conceptualized and constructed the man is that a man is of self-import. A man should be a person of influence. A man should be a person of power. You move lower down, and the society expects that a man who is of influence, power, and a man who should be of very high level of status in the society should not go below that. If we talk about awareness of health, whichever, whether it is NCDs, the triple burden amongst men, we know that it is still commensurate with that need. The man that has been constructed as an all-knowing, all-too-powerful being is not allowed to seek help in the eye of the woman and in the eye of fellow men. A man, if you talk about the help-seeking behavior of a man, which has been deconstructed here, a man is not allowed to cry. And I'm so happy that today we are deconstructing that, and we are allowed within this room, Mwalimu, we are allowed to cry today. So we need to close the doors and we need to start crying, because the crying starts from here. So this too powerful man, paradoxically, again, has been marginalized when it comes to health systems. We understand that from the 1990s and the 2000s, the way the health system has been structured, the programs that have been, developed for donor funding and heavy financial support have excluded men. If we talk about women, reproductive, child health, a lot of money has been channeled towards that. This man, again, is expected to be a client. And our senior, Dr. Willis, again deconstructed it. That a man coming with bladder outlet obstruction is not passing urine. A man who is crying on the floor, and my senior calls me and tells me, go and put a suprapubic catheter. You find the man on the floor. How many times do we get men interacting with these skewed healthcare systems? It is not usual. Many times when a woman is giving birth, they'll interact with the healthcare system. When a woman is to take the child for vaccination, they will interact with the system. So these significant life events have allowed women to interact with these programmed healthcare systems more than men. So historically, and where money has been channeled to, men as clients have also been excluded. So the awareness levels of these men in terms of healthcare, the awareness levels are very low. We have been marginalized. As clients, we've been told we are very human beings. We should not cry. We should not show any self-help seeking behavior. So Mwalimu will say that the awareness levels are very low, and the society has made it very difficult for most men to interact with healthcare systems. Thank you.
Thank you, Dr. Hongo. Just to disclaimer, I met this young man on this stage. That's why he's the only one I greeted. But we meet in another setup of learning where I teach surgical discipline. But we are here to appreciate the barriers, the challenges, and hopefully out of this, we then have some solutions, some ways forward, and we become some of the champions to seek out men. Those first you begin with the one close to you, and then you go to the ones who seek your service, whether they're paying or not, and those that you have influence over. So that's my hope. As I sit here, I would like to go to my right and ask Nelly the male targeted approaches that he thinks with these men that we know and the others out there, our sons, our brothers, our colleagues, what are the approaches that we can take from the African context to tackle that silent emergency, specifically around NCDs?
Yeah, thank you for that question. And you said we lean on our experiences. So I have a mom and a dad who are hypertensive, but my mom faithfully attends all her clinic visits. I mean, faithfully. My dad, on the other hand, takes her medication. Yes, so she comes with her tabs and, he takes some. And same dose. Yes, same dose. I mean, as long as he's measuring and he's feeling all right, That's all he cares. And this leads me to my point, and to answer that question, Dr. I think fundamentally our healthcare system is very skewed towards curative rather than being wellness centers. So the thought of you as a man going to queue beside someone with a diabetic foot, for example, or an accident, someone bleeding in front of you, and all you need is a blood sugar check or a blood pressure measurement, you're like, that's not the place for me. Yeah, that's a waste of time. I will go sort myself out with my wife's medicine. So I think this is one very simple, intervention that we need to look into in terms of reorienting our healthcare center, and especially our primary healthcare centers where our people are, towards wellness and not just curative places. And all it would take is perhaps set a day, for example, at the nearest health center or dispensary, and advertise that in the churches, that it is Wellness Wednesdays or maybe Saturdays, where men can come and women alike to just get tested, to just get measured. That's one approach I think would work. The second one is peer-to-peer support. And especially in NCDs, chronic diseases, it's a lonely path. Injecting yourself, taking your meds, it really takes a toll on you psychologically. Back in 2012, when I practiced at Kiragoya District Hospital, we started peer-to-peer support for diabetes patients. We also started the Kenya Defeat Diabetes Association, that is a peer-to-peer support association for patients. And it still exists till today with over 3,000 support groups in the country. That's a very good model that can also work, especially in our rural areas. We've seen it really thrive in Nyeri, in those counties, because these are our fathers, our grandmothers, our uncles who have retired, and they have their fellow peers. If I don't have blood glucose strips today, I know I can go to so-and-so and borrow some. So it breaks stigma, it shows you're not alone, and it encourages better health-seeking behavior, as Dr. Ari was saying. So I think those two main strategies in terms of our healthcare system would really work as an approach. But I think the others, which are a bit higher level in terms of how we approach it as policymakers, is a multi-sectoral approach. So if you today will tell me to run in my estate, it's complicated. It's a concrete jungle, isn't it? By the time you do a few kilometers, some cars are hooting at you. And so the challenge is here. In this room, who do we have from the agriculture sector, for example? In this room, who do we have from the city planning department, right? In this room, who do we have from the Ministry of Financing? Because we need these initiatives financed, and not only donor financed, but also domestically financed. So I think we health people will need to stop speaking to the choir and preaching to the choir, and get to this, collaborate with these other multi-sectors, because NCDs, if there's any diseases that impact other self-determinants of health, it's NCDs, because you're with this disease for a long time. So it eats into your resources, it affects your children's education. So the ramifications are really grave. So I think at a level of policymakers and people in the business industry and foundations like ourselves, multi-sectoral approach in our programming, in our engagement really needs to happen. So I'll pause there, Dr. Ari. Thank you.
Thank you. As you pass, we'll get back to you. We'll be wanting to hear how which we are social people. We like community. And some of us, those men depend on us, those grandfathers and fathers and uncles. How can we, for lack of a better portrait to use, the way the West does, they bring it, but there are some strings attached. How do we ensure when we are supporting them in other areas financially that we are also attaching health-seeking behavior as one of those. I'm just throwing that to you.
A quick response. Have you enrolled them for NHIF, for example?
Yes, those kind of initiatives. Before you send the money which goes to smoking and drinking, are you ensuring that health is at the forefront? Emma, kindly tell us some of the areas in which innovations and simple innovations are wading towards tackling the NCDs in men. And what do you see in terms of beyond the present in the near future?
Excellent. Thanks for the question. I think technology can make a significant impact in many different areas. My background actually before I moved into health insurance was in pharmaceuticals. I spent 18 years with GlaxoSmithKline. And the development, the biological technology innovation of having low cost, easy access, temperature-controlled medicine, that's happened over the last 20 years. For heart disease, for diabetes, there are many very easily accessible, low-cost medicines. That innovation continues, but at the moment, there are those solutions there. So what is the next step that's required is around the intervention of screening. So I talked a little earlier about screening. We now have excellent point of care screening. So from blood pressure to blood glucose, BMI, these all can be done easily in a primary care setting. And we can plug those results into an iPad or an app. And if there is not a doctor or even a nurse administering these tests, they can be rapidly sent immediate time to a clinical expert who can read them and in real time understand if there are high risk factors and that individual needs referral or medication or not. And I think that's a really important intervention that is happening now. And as we move into the future, be good to know who in here is wearing a smartwatch, like a Garmin or an Apple that's tracking their heart rate. Anyone in the room? Yeah, quite a few. So if I look at my heart rate as I'm on stage is a little bit high, but you can track these things permanently. And we're also tracking our our oxygen levels. And this, I think, is the future. So if you ask me what's happened in the past, we've done a lot of medical intervention. What's happening now, it's telemedicine and that kind of point of care testing technology. In terms of what's happening in the future, it's about wearable devices. And soon we will have much more than just the heart rate and the oxygen levels. We're looking at blood glucose tracking that you could wear permanently, blood pressure, etc., where you can constantly track this in a high-risk individual and intervene much more rapidly. I'll pause there.
Thank you. I hear that and I'm asking myself, the utility of some of those innovations and men lending themselves. We are used to have ego and we want independence, we want to be in charge. But we want that information from our other players and healthcare providers. So let me ask Dr. Hongo, just within a minute, tell us the challenges that men face beyond what you said around access and quality care, around NCDs, specific challenges that you think need to stand out as we come now towards the audience to give us some questions.
Thank you very much. Men are supposed to provide. So the first mega challenge men face, as we've stated, is that they are mostly at places of work. This particular challenge, in my opinion, is a big opportunity for us to move these protective, preventive, and promotive healthcare services to their spaces, social spaces. Men, we understand that the financial toxicity that they go through in any illness is higher than what women would go through. In my opinion, again, it would be important that we find structured ways of, when we talk of UHC, let UHC also be a reality. Let us move it closer to people to be able to increase the uptake. So those are the key things, that the challenges of and above what we know that men face currently, and there are opportunities for us to invest in and increase the uptake of these preventive services. Thank you.
Thank you. Kindly prepare your questions. Let me see by a show of hands anybody who has a question. So I have two. A third one. So there are 3 there. So, so as I pass the mic to him, I'd like to my right, you start preparing to tell us something about the role of community in supporting the men in the fight against NCDs, and a bit on blended financing. So I would let him ask the question, then as we respond, that fits in.
Mine is really a question, but a comment to Nelly. Thank you guys for the discussions on NCDs. You know, Nelly posed a question, where are the people of agriculture? Where the Minister of Finance? And very nicely, she told us we are in church, we are preaching to the converted. The fact that you're here is you heeded that call that men's health is important. And so I think, Nelly, what I'm saying is, could we, as partners here and with MasterCard and many other institutions, find some kind of a momentum towards keeping the men's health discussion on and bring other partners, including the financiers, healthy nutrition, agriculture together in your own strategy as MasterCard? And you know, you do so much for Africa. And if you feel that you can rope this subject into your strategy somewhere, and somehow you can count many partners that are here present today to be ready to join forces. So can you help us get out of church?
Thank you for that comment. She'll respond, so he'll be next, but respond to the community elements. So the mic needs to go to
Dr. Amit, let's meet at the red tent behind there.
So yeah, then there's a gentleman there after that.
Oh yeah, I can go. Yeah, thank you very much. The discussions have been great. Since morning, we are only talking about men at the workplace. And I'm thinking this is the orientation we have as we sit in this room, because we are all having workplaces. But majority of the men actually are not in what we are calling a workplace, isn't it? We talked about dispensers at the workplace. So I think we need to bring this down to the reality of the population we are dealing with. We also need to think about what are the structures that are there. So this morning, we said that a lot has been done on women's health, especially family planning and maternal health. And there are so many things we can learn that we can anchor a movement around men's health. Because some of the things we may propose right now, the next thing will be, can we write a proposal? Can we look for a funding agent? It is good. But at what time will we reach this community, our boda men, our farmers who are men, our herders, the pastoralists down there with this information? So I want to make some proposals or some thoughts that we can carry and looking for at what we have learned over time. We have a whole group of community healthcare workers. And I'm glad that the current government has been talking a lot about streamlining and formalizing that engagement a bit more, which is good. Among those community healthcare workers, we have a group we call community-based distributors. For those who are in family planning and maternal health, the community-based distributors are hived off from the community health workers. They are trained a little bit more to be able to provide short-term methods for family planning, including an injection and something else. So why can't we do that for NCDs? Why can't this community-based distributor carry some glucose sticks to test? When she or he goes to the community, talks to the woman, why can't they talk to the man? Why can't we have the innovation around maybe what kind of a blood pressure machine would be useful in the community that can be put, not very bulky, put in that community healthcare, the community-based distributors bag, because they have bags, and can be able to holistically address community level. Now, the structure, allow me to just talk a little bit more. The structure around how the community healthcare works, they also have what we call referral forms. So if they interact with a woman or a child and they need referral to a facility, they usually help them with a form and refer them to what we call a link facility. Why can't we look at that structure? where you educate and you say, if you take their glucose looks like this, do a referral form to the local.
Thank
So
you.
I know I can talk a lot, but I'm just saying, let's stop being in the workplace. Let's go to the community also. Thank you.
Thank you. I had asked the panelists to mention how can the community, beyond the community healthcare worker and distributor, how can the community in general support men? So if she can expand on that and just speak to it now as we wait for that question, then the last one will be from there.
Okay, wonderful. I think she just got everything out of my mouth. So when we speak community, of course, there's the immediate caregivers. I think those are people we always forget. So in this case, then it becomes more inclusive. So there's their wives and their aunties and their daughters and sons, right? So we need to target them in terms of targeted messaging, targeted awareness, and actually linking to your point, our awareness when we talk about the workplace, we don't mean only the white collar. We mean those Juakali artisans. How can you get to them? What kind of messaging do you get? So it's all about getting the men where they are. Let's not wait for men to come to us as healthcare professionals. Of course, the messaging will be different. The kind of packaging of the information will be different. It has to be how it relates to them. And that's the strategy for outreach that we employ, especially in NCD. To your point on community health, yes, there's a light at the end of the tunnel. We do have an NCD, and I think Dr. Marete is here. We have an NCD module for community health workers in Kenya, which they are trained on. And I can give an example of Makueni County, where they actually have glucometers that they go around testing and blood pressure machines, and they have the referral note, the form 100 that they refer to the health center. Now, the challenge is this, which is the question, Dr. you asked me, financing. Who finances those glucometers? First of all, even those community health volunteers, they are not paid. Yeah, they are not paid. And so how do we sustain that model? And so I will double click on what you had asked me, if you allow me, on financing NCDs, which are grossly underfunded. And someone pointed, we've invested a lot in reproductive health, in communicable diseases, for example. It's very unfortunate that a HIV patient so obese comes to get the ARVs from you, but you cannot think of taking their blood pressure. Unfortunate, very sad. And yet that's a person who will go down with a stroke, yeah, and not necessarily because of HIV. So we need even a paradigm shift, our healthcare workers reorienting our healthcare system. So going back to the healthcare financing bit, there's something called blended financing that has been used in some countries where private money and foundation money, or what do you call it, donor money, quote unquote, comes together to be able to actually de-risk the private investment, and so that then we can be able to scale some of these interventions. And that's something that we need to speak and explore instead of going alone. The foundation, for example, does this intervention, goes alone and forgets vitality, for example, as we are going in, or forgets organization XYZ that's producing glucometers. So I think we need to think through financing in terms of a blended form of financing that will help de-risk the environment for the private sector, but then also ensure that our interventions are integrated, first of all, and that they go to scale is something that we need to think. Thanks.
Thank you, thank you. I know because of time, I'm rushing you. There was a question there. If we can have it.
Thank you, Chair. My name is Meshak Ndolo. I don't have a question. I only have a contribution to solutions in this very enriching conversation. I have 3 points. They're very brief, so don't imagine I'm going to take a long time. The first one is that, yes, let's find men where they are. We are all enjoying the World Cup now. Are we reaching the men where the World Cup is? And can we be diagnostic in identifying these opportunities all the year round in a decade so that we plan ahead for them? But how can we plan? Oh, I thought I was being heard. Am I being heard now? Okay, thank you. I was just saying that I agree with Nelly about reaching the men where they are. And my emphasis is that let us also be not only opportunistic, but also plan. But you cannot plan without evidence. And so what data do we have about the men's health and men's health challenges in whatever form they come? Is that data being generated? Is that data being analyzed? Is it informing policy and planning, resource allocation and investment? Is it informing the attitude of men that has just been brought out? Because men are focusing a lot on social media. What are we doing on social media to make men now begin to appreciate that my own health, just like we say, you lose a woman, you lose a society. So you don't take care of a man's health, you destroy society as well. But let me get the bit. I know my good friend Josephine has talked about discussion has gone on workplace issues. I wanted to bring another dimension on the workplace. Workplace is not just the office. Yes, it is also your caddies, but about everywhere. But are these workplaces also connecting to the families of the people working in those places who are men? Are there certain things that we can do better if workplaces get to know about the families or inform families or make families be involved? People only get to families when one has died. That is when workplaces are rushing to collect money to escort those who are going to be laid to rest. Let's start early. Sometimes we find that men have responsibilities or jobs whose nature is very demanding for them. Very demanding. I once worked in a building called the National Treasury as an advisor. And the 5 years I was there, one of the things I observed, people come at 6:30 in the morning and leave at 9 or 10 in the night. I, for one, gained weight that shocked me. So I started advocating for a need for people to exercise. And by the time I was leaving, there was a gym in the Treasury building. And we shared this information about taking action to other places as well. In the Teacher Service Commission, when we were starting AIDS control units, it was just focusing on AIDS. But later, they decided to have it as a workplace and then decentralized workplace attention for teachers. How are these workplaces paying attention to men's health? That's number one. And I've talked about the data and the importance for planning. The second point is the cohort effect. Cohort effect is so important in the male population. You can see us celebrating goals in the stadia, but when you go to workplaces, the cohort effect is not visible in relation to health. If you go to the gyms, there are more ladies than men. And we make the cohort effect also be influencing men's health. The jogging population, when you go alone, you have very few. But the consistency is another issue. So that's one problem that I think we need to address. Finally, the question of the proportion of policymakers, male versus men versus women. I can tell you, the people who plan, who decide where resources go, 78% of them are men. How come we are not remembering ourselves? Thank you.
Thank you. Thank you. I know there was a lady there with a hand up. Okay. Meanwhile, I'll have him comment on places of work.
Thank you. I work very closely with the Institute of Human Resource Management. They call it places of work. Places of work. And it has been said, we need to reach these men at places of work on the digital platform. It is working. We need to invest. There are investment cases. Recently, the investment case for mental health in Kenya, funded by the WHO, has been presented, NCD presented. We need to invest more in this protective, promotive. We say that men look up to fellow men and women look up to men. Having champions, NCD champions in our societies that we look up to. We have a leadership that we look up to. If our president, His Excellency, Dr. Ruto, can be the champion for NCD, for mental health and wellness of people in Kenya, then there'll be a difference in the direction that we'll take. The uptake of these protective, promotive services at the PHC level, the primary healthcare level, will be very high if they are male-friendly. the more friendly, the way we made maternal services more friendly for female and children, the more friendly we need to make these services male friendly and have men wellness clinics and the like. So we are so aligned on that, and we are here to allow men to open up and talk about their healthcare needs free of this historical grounded masculinity. Thank you.
Thank you very much. I hope I'm not closing out anybody from the audience. Just in the event there is. So I'll just do in a conclusive manner. They'll make some comments around the national, the regional strategies that they think the government needs to speak to. We are here, we have not just the jobs and the budgets we brought ourselves in with, we wear different hats. We also have relational capital. Some of these conversations can be held in those spaces. And it's my hope that as we discuss this, you probably know the director of fiscal policy, you know somebody in another sector element of this society. We can also initiate those. I thought to mention other places which have influence in society. That includes the religious groupings and formations, that the HIV, maternal health, even COVID, the Interreligious Council, they had to use those to cause their messaging to go far. So how can we reach those platforms as well? And not forgetting families. Then the young ones, we always say the young are the future. The schools, the primary schools, the high schools, the population there. While everybody's thinking we have a lot of people, can we see those as a resource and as people who can be molded to take up this message when they're still young and green? So that speaks to the curriculum, that speaks to the role modeling, the career messaging, those alumni groups. That's what I'm thinking about. But I wasn't to speak that. I want next to tell us a little more about the last question I mentioned, national, regional, and if you can touch a bit on injuries, trauma, and because even the research element, just as we close. So you have 2 minutes each, then we pass over. Thank you.
Thank you. I think I want to just close on probably 2 key points. The first one is that it's been said often, you can only go so far alone. In partnership, we can do so much more. So we have the private sector, we have NGOs, we have government. If we each operate alone, we can only go so far.